Welcome to the Preventive Medicine Podcast. Help us change the paradigm of medicine from keep people alive to help people thrive, one episode at a time. And now, here's the show.
So kind of piggybacking on the screening idea. So, I mean, you run into screening screening versus diagnostic testing all the time. It's something you've talked about quite a bit on some previous podcasts you've done recently. When it comes to teaching your medical students and residents and just teaching the general public and patients, and you talk about screening tests, what's one thing that you kind of would like to get across to different physicians or just people in general about why the allure of more screening is problematic?
Yeah. So I don't know that I can reduce it down to one thing. I can give a bit of a spiel, I guess, on the topic and see where it takes us. I think that when I'm working with the students and the residents, I think one important point of distinction is difference between diagnosis and screening. And so, a lot of times in the inpatient setting, we're dealing with patients who are presenting with symptoms, and we're tasked with trying to figure out a diagnosis and a treatment that can then, alter the natural history of that condition. And that obviously in that context, I'm encouraging them, working with them to learn about developing a good differential diagnosis, understanding like Bayesian inference, where they can have an idea of where their pre-test probabilities are, what they want to do to alter their post-test probabilities in terms of history, examination, ordering tests, things like that. Having an idea of the test performance characteristics. You don't have to know the exact percentage of sensitivities and specificities and things like that, but having an idea of how likely is this test to alter my thinking and subsequent management in this patient. Anticipating your plans at least a couple steps in advance is something that can be really tough to do when you're earlier on in your training. And so the idea of, hey, you say you want to order this test. This is an academic institution. I'm okay with letting you order this test if you'd like, but I want you to consider, what are you going to do with the information that you get? What if it shows you this? What are you going to do? What if it shows you that? What are you going to do? Are those answers the same? Okay, let's just not do this thing, as an example. So avoiding shotgun labs, avoiding routine labs that aren't necessarily indicated, a lot of times daily labs, just having more numbers to present on rounds seems like, you have more data, you're better prepared. Ordering echoes for, a syncope patient with a normal EKG that doesn't need an echo. And then you're going to find stuff that's going to lead to more testing and intervention. And then somebody's going to recommend they get Q6 monthly echoes for the rest of their life or something. So there's all kinds of consequences. And again, that's just basically conveying the degree of responsibility that they have and the amount of harm that they can do, whether, iatrogenic medical harms or psychological harm, financial harm, et cetera, that you can do to somebody by finding something that didn't need to be found, even in the course of a diagnostic workup. When it comes to screening, the task that we have is even harder, because we're looking at asymptomatic individuals in the context of screening, and doing things to people who look fine and feel fine, searching for problems under the guise of preventing downstream morbidity and mortality is even harder to do in somebody who has no symptoms, no complaints, and overall looks okay. And so in that situation, we need even more evidence of benefit with respect to morbidity and mortality if we're going to be taking what would have been called healthy people and turning them into patients. If you're going to do that, you better have some good evidence behind what you're doing, that it's actually going to help the person, because in the absence of evidence of benefit, all you have is potential for harm. And so, just a common example, if you go through a general continuity clinic for general medicine doing primary care annuals, quote unquote, and they want to do an annual CBC on this person. It's like, okay, why? Is there evidence to support annual screening for somebody's white blood cell count and hemoglobin, et cetera? No, you don't need to do that. So I think, the way I approach this in practice with them is basically when they want to do something, I ask them to either support what they're doing with evidence or support what they're doing with an explanation of how this is going to alter their subsequent diagnostic reasoning, their subsequent therapeutic plan, et cetera, because there needs to be some tangible benefit to be had by doing a particular test or evaluation. Whereas if I ask them how this is going to help either in the current diagnostic process or from a screening standpoint, and I get a shrug, then I'm forced to think that the seesaw is tilted exclusively in the direction of harm here. And so I'm unconvinced that we need to do this.
I was going to say, being the academic physician you are, you of course had us do some homework before this episode, and both of us read Overdiagnosed, which was honestly a really good book. And I appreciated that you had us to read that, because it opened my eyes to a lot of things that you're talking about right now, and a lot of the problems that we're going to face in medicine more and more with the increasing capabilities of technology and so forth. And one of the things I talk about in that book is really that one of the barriers to prescribing less tests and less screening measures is that they're kind of sold to patients and to physicians saying these are beneficial. So when you look at a patient, or when you look at like an ad targeted towards a patient or to the lay public, they see, all right, we can catch prostate cancer before it happens, and I'll be saved from cancer, which is cancer is bad, right? So how do you kind of balance? And then on the other side, when you have physicians that are like on the checkbox model where they can check off that preventive care, it's very alluring just to be able to say, all right, we order this for the patient. So the question here is, how do you kind of fight that in a sense, or battle the allure of both physicians checking that and then the patients coming to you and saying, hey, I want to make sure I don't have cancer. How do I get this test?
This is similar to what we were discussing earlier. The problem crosses multiple layers and multiple levels here. Obviously, there's the understanding among the lay public of cancer, like you said, as an example of something we screen for. Cancer is bad. The assumption is that early detection is always better. The idea that more information is always better. Furthermore, and all of this with respect to cancer is kind of underlined by the assumption that once you have cancer, it will inexorably progress and cause badness down the line, which I think that's probably like the biggest fallacy here. And that just represents a misunderstanding of cancer biology and the result of both poor dissemination of this information, as well as a lot of like the public health kind of campaigns around cancer and cancer screening are like extremely emotionally driven in a lot of contexts, right? Because almost everybody knows somebody who's had cancer, and whether they had a good outcome or not, it's a very challenging, taxing, emotional experience. And then that drives the desire, oh, that could be me. I need to know, do I have cancer? If I have cancer, that's gonna progress and it's gonna be awful, et cetera. Whereas in reality, just about everybody has cancer in some capacity, i.e. like malignant cells that can crop up here and there, right? And as you guys probably learned in your immunology class, we have this amazing like immune surveillance system that can go through and take care of a lot of those things, such that we, to whatever extent we develop unknown pre-malignant or malignant lesions, that they can in many cases regress, or in other contexts, they may not progress. They may be slow growing, indolent lesions that never go on to cause any problems at all. And this is just a reflection of the huge heterogeneity in cancer biology as one specific example of something that we screened for. And I think that, people might have a difficult time adequately weighing the risks and the benefits here. So they might say, I don't really care what the harms are of getting this test done. I'm not worried about any of that stuff. If it can find cancer, it'll save my life. The assumption is that if a screening test finds something, then it has therefore worked and it saved your life. And that's another huge fallacy, because that gets to the idea of overdiagnosis, just diagnosing things that were never destined to cause any morbidity, any mortality, any symptoms at all in many cases. And this is something where looking back through medical history, again, can be very educational and informative if you look through various screening interventions that have been done in the past, such as thyroid cancer screening. There's been a bunch of screening programs in pediatric populations, neonates, that have then ultimately led to where newborn screening is today. Which is more based on evidence than it has been in the past. And just a whole bunch of things that we've realized that, hey, we screened a ton. We found a ton, because that's what screening does with very highly sensitive tests. You catch all the true positives, you catch a bunch of false positives that require subsequent confirmatory evaluation. And when you catch something, you are usually inclined to do something about it, right? Because that's the idea when you're thinking a step ahead with your test. I'm doing this test because if I find something, I'm going to do something about it. And that might involve treatment, that might involve surgery, chemotherapy, radiation, whatever, or ongoing imaging follow-ups for the rest of your life, or whatever the case is, whatever plan of action there's going to be. And all of those things can have accumulated harms that ultimately may outweigh any potential benefit in the case of an overdiagnosed case that was never destined to cause any problems. And then at the top layer, that's kind of what you're talking about. So there's the patient level assumptions about more information always being better, which is definitively not the case. There's kind of clinician understandings of this stuff, and then kind of the systemic incentives that are at play. So an example of this that you kind of alluded to was like the checkbox and these quality metrics that somebody might be their practice performance might be evaluated against these quality metrics. And of course, all the quality metrics themselves should be based in evidence, right? They should be like, oh, we have good evidence that if you actually perform better on this, that it'll help patients. But of course, there's that idea that once you start measuring something and that measure itself becomes the target, you might be missing the actual forest for the trees there. So the underlying point here is that a lot of these screening interventions, the clinicians themselves don't even have a good understanding of how much benefit they stand to offer patients compared to the potential harms. And so one way that I like to address this is there are an increasing number of kind of clinical decision-making tools available that can help to guide these conversations, and they can help to guide them by even producing like visual pictorial illustrations of NNTs and NNHs, for example, because we'll have, for just an example that I might come across regularly, we might admit somebody who's in maybe their late 70s to the hospital for some COPD exacerbation or something like that, and the intern might recognize, oh, they have an iron deficiency anemia, and therefore obviously, that's colon cancer until proven otherwise, iron deficiency anemia. So they should probably undergo this diagnostic evaluation. Or even if there's not any evidence, they might say, oh, they're due for their next screening. And again, an asymptomatic person where you're not pursuing that diagnostic evaluation. Well, we have patient decision-making tools where we can input all the information, demographic information about this patient, and it can give us a better idea of what are the odds that this patient actually benefits from undergoing that sort of an evaluation compared to what are the odds that they are more likely to be harmed. And almost universally, whenever I prompt them to go through that exercise using one of these tools, like the UCSF ePrognosis tool, their jaws drop at the end. They're like, oh, wow, I wouldn't do this if I were the patient. And I'm like, that's exactly what I want you to be thinking about. What would you do if you were in this situation? What would you want your parent to do if they were in this situation? Because it's really easy to tell a patient, just go do this. But when you actually are faced with those kind of benefit and harm trade-offs, what would you actually do? And very often they end up realizing, oh, we have a lot more potential to harm this person than to help them. Maybe this isn't the best idea from a preventative standpoint if our goal is to actually, promote quality of life, quantity of life, health span, things like that.
Preventive medicine is an incredibly important topic. I want to thank you for taking the time to watch this video. For the full episode, find us on your favorite podcast streaming platform. If you enjoyed this video, don't hesitate to hit that subscribe button, like this video, and share it to keep that message spreading. Thank you once again for watching this video, and we'll see you in the next one.